Good morning, everyone. Today we are going to continue with our book club. Our book is The Fundamentals of Diagnostic Radiology. Today we are going to continue with our talk on the chapter of non-degenerative diseases of the spine, and we will start where we ended, talking about the vascular disease of the spinal cord, and then we are going to continue on the degenerative disease of the spine, in which we will talk about the lumbar spine, the disc disease, and the spinal canal stenosis. This talk was originally prepared by our resident and our colleague, Dr. Ibrahim Abdulwahab, and will be presented by me, Dr. Ahmed D. Abdulwahab. Regarding the vascular disease of the spine, we should know first something about the spinal cord infarction. Uh, the spinal cord infarction mainly caused by two major causes. First, after major thoracic surgery, such as repair of thoracic aortic aneurysm, and the second cause is the spinal epidural steroid injection that by mistake enters into the vasculature supplying the spinal cord, resulting in spinal cord infarction. So the affected segment of the cord will appear bright on T2 and on diffusion weighted imaging, just like what happens in the brain infarction. And then there will be atrophy or myelomalacia of the affected segment of the spinal cord. The spinal gray matter in an infarct will enhance to a greater degree than the white matter, as the case of the brain. So spinal cord infarction radiologically is almost the same as the brain infarction, with one exception. In the spinal cord, keep in mind that the gray matter is in the center, while the white matter in the peripheral. So the infarction will be in the center of the cord, while in the brain the gray matter is on the peripheral and the white matter in the center, so the infarction will be on the periphery of the brain. So, infarction of the spinal cord should be considered in the differential diagnosis of any unexplained myelopathy. For example, if we look to this image now, we can. This was an epidural injection of steroid that inadvertently entered into the vasculature of the spinal cord. It shows obviously an increased T2 signal intensity and edema in the area of the conus. And if you look at the axial images, you can see that the gray matter, the butterfly shaped, is hyper intense, indicating it's infarcted. Now, the second topic regarding the vascular disease of the spine is the spinal AVM. Spinal stroke also can be related to spinal AVMs. These lesions are an area of growing interest for two reasons. The first reason is the development of the super-selective interventional neuroangiographic and microsurgical techniques. These techniques has led to opening a new era of treatment of the spinal AVMs with endovascular procedures. The second reason is that the MRI now allowing screening of a lot of patients with unexplained myelopathy. So this leads to the discovery of more patients with spinal AVMs that they were not discovered before. Uh, the term arteriovenous malformation is used as a generic term to cover any abnormal vascular complex, which necessarily violates a number of rather complicated spinal IVMs. There are many classification systems, and most of them are true. But the classification system, the simplest and the easiest one that we will adopt here, is to classify the spinal AVMs into intramedullary, intradural, extramedullary, and extradural. So regarding the intradural AVMs, they are characterized by having a nidus, a center of abnormal vessels within the cord substance. This will cause symptoms by hemorrhage or ischemia because of a stir phenomenon. There will be shifting of blood from arterial to venous side directly through the nidus. Uh, Typically presents in young patients with hemorrhage causing acute paraparesis. Some of them are high flow, visible signal voids within the cord substance will be seen. The others, if they are small enough, they might escape detection even with angiography, and they are similar to cavernous vascular malformation of the brain. And of course, here MR is the primary mean for their identification. For example, if we see this case of proton density and T2 fast saturated images, we can see Obviously, there are multiple flow voids surrounding the spinal cord. Sorry, within the spinal cord. You can see here and here they are within the spinal cord associated with cord edema, and the cord appears ill-defined due to the edema. And if we see an angiography of an example, you can see here the feeding vessel, and this is the nidus of the AVM shifting blood from arterial to venous side. Now, regarding the extramedullary AVMs, they are located outside the spinal cord but within the dural or the thecal sac. So they will be either in the pia or dura mater. When they are in the dura, they can be as far lateral from the cord as the nerve root sleeves. So the lesion will be, it's typically an arteriovenous fistula. It's a direct connection between an artery and a vein. But keep in mind there is no intervening nidus. So this is the main difference from intramedullary AVMs, that there is no nidus in between. The direct arterial inflow into the local venous system will lead to what we call arterialization of the veins, because the veins are low pressure and they are valveless, so these veins will change into some sort of an artery. They will dilate, their blood in them will be pulsating, and they will enlarge and they will be much more visible. The dilated vessels, the venous plexus in the spine, around the spinal cord, they call it the coronal venous plexus. These vessels will dilate and they can be visualized by MRI, but this is very dependent on the technique that we use to do the imaging of the spinal cord. Previously, with the older imaging system, the CSF flow will result in an artifact that appears like tubular flow voids might be mistaken for vessels, and this will lead to false positive examination. However, the various motion suppression techniques that are now available will reduce this problem. They use cardiac gating, and this will result in removal of this CSF flow artifact, and it will be much more obvious if the case is an equivocal. Alternate examination like CT of the spine, CT angiography, and conventional angiography can be used. Catheter angiography is the gold standard till now. It provides a way for embolization and the closure of the fistula and treatment in some selected cases. There is what we call spinal dural arteriovenous fistulas. These cause symptoms through venous hypertension and congestion of the cord and edema. The edema can easily be detected on MRI as increased T2 signal intensity. Typically, it is seen within the conus of the spinal cord. Sometimes it enhances. The reason for the cord enhancement is not fully understood. It might be due to breakdown of the blood-brain barrier, might be due to some sort of capillary leak due to venous hypertension. These lesions, the spinal dural arteriovenous fistulas, there are different opinions about them, but most of the opinions are in favor of their being acquired rather than congenital arteriovenous fistulas. For example, if we see here this case, there are some flow voids or hypointense tubular signal intensity in the CSF on this T2 weighted imaging. Again, you can see here and you can see here, but unfortunately this is not an AVM. This is just a CSF flow artifact. So this is completely normal. It's a flow artifact. That's why we need to focus on the use of CSF flow compensation techniques. If we see here, we can easily see that this MRI is done using a compensation technique, CSF flow compensation technique, and you can see here there are tubular flow voids, the true ones. These are not an artifact, and they are surrounding the spinal cord. You can see them here, and you can see them here. And of course, if we give contrast in the MRI, these will enhance, while if it is from CSF flow artifact, they will not enhance. So post-contrast MRI is very important in any case of suspected spinal AVM. A spinal dural AVM can be seen here as a tubular flow voids surrounding the area of the conus of the spine, associated with edema of the conus of the spinal cord, as we said before. And this is an angiography of this AVM. You can see the catheter here entering into one of the supplying arteries, and there is obvious shifting of blood from arterial to venous side through these dilated tortuous vessels. Now, another subject regarding the non-degenerative disease of the spine is the congenital malformations. Of course, here MRI is the primary method of investigation of children born with neural axis defects, whether they involve the brain or the spine. Regarding the spine, the neural tube defects that are open, or if they have an associated dermal defect, are usually detected by prenatal ultrasound or even at birth, while anomalies of the neural tube closure, where the skin covering it is intact or it's closed, it may escape immediate detection, and they range from asymptomatic non-fusion of the posterior elements, what we call spina bifida occulta, to severe cord tethering with spinal lipomas. As always, the T1 of the MRI, the T1 weighted images, are very helpful for defining the anatomy. So when we are looking for anatomy, we need T1 images, while if we looking for pathology, the T2 weighted images will be much better. The T1 will help us also in detecting of the fat components that are seen in many of the developmental disorders. The standard pediatric spine examination for congenital anomalies will include T1 weighted, sagittal and axial images. T2 weighted images are less critical here, as we said previously. If there is a sacral dimple or other skin defect, we can mark it on the skin, for example, by using a vitamin E capsule. Vitamin E is an oil and will be easily seen in the MRI images. Regarding the tethered cord, what do we mean by tethered cord? Tethered cord is a cord in a lower position than normal. If the cord is truly tethered, the conus will be in low position, particularly as growth occurs. First, we should keep in mind that the conus in the newborn is normally at L2 level, and as the child grows up, the conus will ascend for one or two lumbar segments. It can be difficult to determine the exact position of the conus if the roots of the coda equina that are tethered form a taut mass. They are clumped together like a mass. This will make the determination of the location of the conus very difficult. Not every lumbar intradural fatty deposits implies a pathologic tethering. Sometimes there are small, what's called fibrolipomas of the filum terminale. They are seen attached to the filum terminale. They are incidental findings. They might have, as the name implies, they have fat content, and there will be no symptoms of cord tethering, so we should keep that in mind. These are fibrolipomas. So, for example, in this case of fibrolipoma of the spinal cord, you can see obviously that this is the conus medullaris here in normal position, and there is no sign of tethering of the cord, and you can see the fat signal intensity on the T1 weighted images here, indicating a fibrolipoma, like here and here and here. They are connected or attached to the filum terminale. Regarding intramedullary lipoma, they can be seen in patients with normal or bifid spinal canals, and as with the brain lipoma, it may be discovered incidentally. They are usually thoracic, more common in males, and when asymptomatic, they present with myelopathy, and when they are symptomatic, they will present with myelopathy in young adulthood. If any cyst, hemorrhage, or debris are seen in association with the fat, then we should suspect teratoma. Dermoid and epidermoid tumors, they are seen intraspinally with imaging characteristics exactly the same as in the brain. Both may be associated with dorsal dermal sinus tracts. There is something called implantation epidermoids. These occur during lumbar puncture with implantation of the epidermal cells intrathecally, and that's why we should always keep the stylet of the spinal needle in its place in order to until we enter into the thecal sac. That's how we can avoid having these implantation epidermoids. For example, you can see here, this is a case of intrathecal lipoma that's almost filling the whole spinal canal. This is T1 weighted images, and you can see it here and here filling the spinal canal, and even the cord is not very well seen in these images. There is something called caudal regression syndrome. Caudal regression syndrome, it's just a bunch of sacral anomalies that have been grouped under this name, where the distal spine and sacrum may be hypoplastic or absent, and the conus will have a blunted appearance. We will see an example of that in a while. The caudal regression is believed to be due to insult into the mesoderm causing during the fourth gestational week. It's associated with cardiac, renal anomalies, and there is a high association with maternal diabetes. But subtle forms such as partial spine sacral agenesis may not be discovered until adulthood. In this case of severe caudal regression, you can not see the sacrum at all, and also the L4, L5 vertebrae are completely missing on this X-ray. And on the MRI, you can see blunted conus medullaris, and you can see almost absent sacrum, totally absent. Okay, so this is a very nice example of caudal regression syndrome. Regarding arachnoid cysts of the spine, in the spine they present as masses that have the same signal of the CSF on all sequences, and as in the brain, the primary differential diagnosis will be epidermoid. And again, as in the brain, to differentiate them, you will need diffusion weighted imaging. The arachnoid cysts will have reduced diffusion, while the epidermoids will show an increased diffusion and will appear bright on diffusion weighted images. So this is a case of an arachnoid cyst. You can see here the cyst is causing some mass effect on the adjacent spinal cord, and it follows the CSF sequence on all sequences. Regarding scoliosis, many unsuspected spinal abnormalities present with curvature of the spine or scoliosis. Most adolescents with curvature of the spine, they have what's called idiopathic scoliosis, primary scoliosis. But when the onset is earlier, or if it is more severe, or scoliosis films shows a vertebral anomaly, then MRI will be indicated to rule out intraspinal anomalies. These are collectively the whole thing collectively called congenital scoliosis. They may and the primary cause, such as cord tethering, may be addressed before the spine undergoes mechanical straightening, because the management will be totally different if there is a spinal cord tethering, if there is diastematomyelia. The whole management will differ between one case and another, and that's why we should look carefully for any cause of this scoliosis. And this scoliosis X-ray, we can see that there are a number of hemivertebrae here, and there is a block of vertebrae fused together here, and this is the cause of the scoliosis. And you can see here there are some fused ribs on this side. Diastematomyelia is a pathology, a congenital disorder, in which the spinal cord is split into two cords, usually by a sagittal, bony or cartilaginous spur. Each hemichord has its own dorsal and ventral horn, and it has its own central canal. Most of them occur in the lower thoracic region and are accompanied by vertebral segmentation anomalies, and the settings develop in up to 50% of the cases, and this is called split notochord syndrome. There is a spectrum of severity ranging from single dural tube with a fibrous band or two separate bony canals. Here we should know the difference between type 1 and type 2 diastematomyelia, because in the first type, the type 1, the two hemichords are enclosed together in one dural sac, while in type 2, each one has its own dural sac. For example, if you look at this case of the diastematomyelia, you can see there are two completely separate cords, and again here you can see them separated, and obviously the vertebrae here are abnormal. The image is not showing more details, so whether it's type 1 or type 2 is not obvious here. The thing to know here is that you should continue imaging till you are sure which type is that, which kind of spurs there is. It bony, is it cartilaginous, at which level it is, and what's the length of the hemichords, All of these details are very important to the neurosurgeon who is trying to correct this congenital anomaly. For example, you can see here there are two hemichords and there is a bony spur separating them, including indicating diastematomyelia. Regarding trauma of the spine, in any acute trauma patient, the spine must be evaluated immediately to rule out fractures, because unstable fracture can compromise the diameter of the spinal canal, and this will lead to cord compression. It will lead to paralysis. The plain films at the beginning, before the modern modalities are available, they were the first choice in the emergency department because they are quick and they are inexpensive, and no interruption for the resuscitation efforts. But recent data shows that the conventional radiography remains perfectly adequate in low risk cases. However, after severe trauma, CT scan of the cervical spine will take just few extra seconds, and after the head CT. And subtle lesions such as the fracture of the filament transversorium, which contains the vertebral artery, will be easily detected on the CT scan. And the CT studies are very helpful to define the relationship of the bony fragments. Acute osteoporotic compression fractures are typically due to minor trauma because the vertebrae will be osteoporotic and weak, and this population will benefit from what's called vertebroplasty or vertebral augmentation procedures. For example, in this case, you can see there is a loss of height here with mild bone marrow edema indicating recent event, and there is some bulging posteriorly into the spinal canal with increased T2 signal intensity of the spinal cord indicating cord edema. Here we should be careful that if there is any evidence of bleeding or hemorrhage or hematoma within the cord, this indicates a bad prognosis. So we should be careful to look for these signs and to report them. Regarding epidural hematoma, as in the brain, they are extraaxial, or more appropriately in the spine, they are extramedullary hematomas, can follow trauma. There are some important distinctions from that of the brain. The subdural hematomas in the spine are rare. The epidural are much more common, while in the brain the subdurals are more common and the epidurals are much less. This happens why? Because the dura is fixed to the skull bone in the brain, and there is no potential space between them. The space is very tight. That limits the amount or the number of the epidural hematomas of the brain, while in the spine this is not the case. The dura is separated from the bony vertebrae by fat, and this fat creates a potential space that contains veins and venules. These are prone to rupture, and they will bleed, resulting in epidural hematomas. And the trauma with or without vertebral fractures can tear this vein, resulting in epidural hematomas, and they can grow over time and will lead to cord compression, while the plain films are completely normal. So the CT may detect these epidural hematomas in the lumbar spine. Why? Because there is fat which can contrast the blood. But the thing in the cervical, if it is in the cervical or thoracic spine, there will be less useless unless intrathecal contrast material is given. So MRI will be much more helpful here, given its ability to image the content of the spinal canal non-invasively, and it will detect the blood breakdown products. We should keep in mind that epidural hematomas are more common in areas where the spine motion is more, like for example in the cervicothoracic junction. You can see here there is a spinal subdural hematoma. Here blood and fat are together. Both of them appear as a hyperintense signal on this T1 weighted image, while in the T2 weighted image you can see that the fat is slightly less dense than the CSF or the blood in this case of epidural hematoma. Again, epidural hematoma in the cervical spine, you can see them on the T1 image. In the methemoglobin state, they are hyper intense on T1 image, and they are causing spinal cord compression and displacement to the right side. Particular form of injury is the nerve root avulsion. The nerve root avulsion, the most common site is the brachial plexus, which extends from C5, 6, 7, 8, and T1 spinal roots. These are injured commonly during birth due to birth trauma, and this will result in what's called Erb's palsy, in which the shoulder will be adducted and it will be internally rotated, and the elbow is extended and pronated. The wrist is flexed, all from injury of the C5, 6, and 7 roots. And the clinical diagnosis usually nowadays can be easily confirmed by MRI or CT myelography. What will happen when the nerve root is avulsed? The CSF will leak into the epidural space through this, let's say, opening in the arachnoid dura from the missing nerve. The thoracic spinal nerve, except T1, and the nerves of the lumbar coda equina rarely undergo avulsion. The most common is the brachial plexus. So while MRI is often practical in the acute setting, it has become superb non-invasive tool for evaluating the neurologic complication of the MRI is not practical in the acute setting, but it is a superb non-invasive tool for evaluating the neurological complication of a trauma after the patient is stabilized. And it increased our understanding of the spinal cord injury and facilitate the predilection of the long-term outcome. For example, you can see here this is a case of spinal root avulsion. You can see here there is a spinal nerve, there is a spinal nerve here, there's a spinal nerve here and here and here going into the exit foramina, while on the opposite side there is nothing. There is just due to this avulsed nerve root fragment. Again, in the axial images you can see the spinal root here and spinal root here, while here there is nothing. There is just CSF indicating spinal nerve root avulsion. Now we have reached the final chapter of the neuroradiology, which talks about the lumbar spine, the disc disease, and the stenosis. And here we are going to talk about the lumbar spine imaging modalities, the disc disease, the spinal stenosis, post-operative changes, and we'll talk about bony abnormalities. So, regarding imaging methods, regarding the imaging methods, we can use both CT and MRI to image the lumbar spine to determine the disc diseases or the degenerative diseases. Although the differences between CT and MRI are not that big, but the major advantage of the MRI is that it can show evidence of dehydration of the intervertebral disc, the degenerative changes of the disc, which is not available with CT scan. And to achieve the highest degree possible of accuracy, we need continuous cuts from the 3 to 5 millimeter thick cuts, axial images obtained from the midbody of at least L3 to the midbody of S1 in a continuous manner. There should be no skip areas. And why there is no skip areas? Because the most common cause of failed back surgery is missed free fragments. If we have skip areas, we can miss these free fragments, and they can go undiagnosed. Angling the gantry parallel to the disc or to the end plate is not necessary because we can reconstruct the images after acquisition. The thing is, if we do the images on the disc, we have an increased possibility of missing free fragments, but the time of imaging will be less. So the disadvantage of making continuous cuts is that the imaging time will be more. So the MRI imaging protocols are similar to the CT, and in the same manner it will take a little bit more imaging time if we get continuous cuts, but we should do it because we don't want to miss any free fragments. Other entities that can be overlooked if gaps are present in the axial images include the conjoined nerve roots. Conjoined nerve roots are also we can miss pars defect or spondylolysis and lateral recesses stenosis. These entities can occur in the dorsal, they occur dorsal to the vertebral body and away from the disc. Thus, the axial images limited to the disc level will not show them because they are at the level of the vertebral body, not at the level of the disc. And they may not be obvious in the sagittal images. And spondylolysis, which happens due to pars defects, can be overlooked. For example, you can see here this is an incorrect technique of acquiring images at the level of the disc alone, and this is the correct technique of having continuous imaging from L3 to S1 in order not to miss the free fragments, not to miss the conjoined tendon, which we'll talk about it later. So, regarding the disc protrusions, till now there is no international agreement on the nomenclature of the different disc protrusions. So disc bulges have been described by their morphology. For example, broad-based disc bulge, it's been said to be a bulging annulus fibrosus, while a focal disc bulge is herniated in nucleus pulposus. But more significantly, most surgeons are not concerned with what's the name applied to what kind of a disc, because the surgical treatment will not differ if it is a bulging disc or a herniated nucleus pulposus. They treat the patient's symptoms and have to decide if the disc bulge is responsible for those symptoms. Most surgeons are just satisfied with terms like bulge or protrusion, adding on to the term broad-based or focal. So up to 50% of symptomatic population have disc protrusions. Keep in mind that not all disc protrusions will be symptomatic. As we said, up to 50% of asymptomatic population will have some disc protrusion. So just seeing a disc bulge on CT MRI does not mean that it's clinically significant. If it causes symptoms, then it's clinically significant. Both CT and MRI will have a high degree of accuracy in delineating disc protrusions and in showing if the neural tissue is compressed or not. MRI can show if the annular fibers of the disc are disrupted by noting if there is a high signal on the T2-weighted images that disrupts the annulus fibrosus. This focal hyperintense T2 signal has been termed the high intensity zone, or what's called his zone, high intensity zone. Although CT cannot be used to diagnose these annular tears, but the clinicians treat annular tears the same way as they treat protrusions from annular fiber when the annular fibers are intact. There is no difference in the treatment. That's why CT and MRI are almost equally good for detecting disc disease. In this example, we can see here there is a broad-based disc and there is a focal disc protrusion, mainly right paracentral, and it's indenting or even compressing the adjacent thecal sac. Now let's talk about free fragments. Free fragments, they are a type of disc protrusion which are very critical to diagnose. Why? Because there is a sequestrated fragment that is separated separated from the disc itself and can migrate either caudally or superiorly to the original parent disc. And the preoperative diagnosis of a free fragment will contraindicate chymopapine, percutaneous discectomy, and for many surgeons, even microdiscectomy. At the very least, the presence of a free fragment means the surgeon must explore either cephalad or caudal during the surgery in order to remove this free fragment. The free fragment can be very difficult to diagnose, and imaging is critical in the evaluation of the spine if any patient is contemplating surgery. At times, it can be even difficult to ascertain if the disc has migrated cephalad or caudal and is still attached to the parent disc, or it's really free. If the disc material above or below the level of the disc space, whether it is attached, really it does not matter. chemopapy and percutaneous discectomy will still be contraindicated, and many surgeons will not perform or would modify their microdiscectomy if they recognize that there is a free fragment. Free fragments are diagnosed by CT by the presence of soft tissue density. It has a higher attenuation value than the thecal sac. It is located away from the disc space. Important thing here, the most important thing is to differentiate it from what's called the conjoined root, which is a normal variant of 1 to 3% of the population. This will result in two roots exiting the thecal sac together through the same exit foramen, rather than through two different exit foramina. Also, tunnel of cyst, which is a normal variant, refers to a dilated nerve root sleeve. It can be similar to the appearance of free fragment on CT, but these tunnel of cyst, as the name implies, they are cysts, and they will have fluid within them, and it will follow the CSF sequence, the CSF signal intensity on all sequences. Also, the conjoint root has a characteristic appearance on the MRI. For example, you can see here there is two examples of a conjoint root, a nerve root, and a free fragment in the spinal canal. The free fragment here, it has a higher density. Of course, this is a CT scan, and the free fragment has a higher density than the adjacent thecal sac. So this is not a conjoint root, while here the conjoint nerve root has almost the same density as the adjacent thecal sac. This is not a free fragment, this is just a conjoint nerve root. It should not be missed. In this sagittal image, we can see here there is a free fragment, and apparently it is still attached to the adjacent L4-5 intervertebral disc. It's migrating caudally into almost the mid-level of the body of L5 vertebra, and this is very important to recognize and to be described. Now, an important entity is the lateral disc protrusion. Lateral disc protrusion sometimes happens. It will cause the nerve root that has already exited the central canal to be stretched. So, although it's not common, it's almost less than 5% of the cases, these discs are frequently overlooked, and they are a source of failed back surgery because they have affected the already exited nerve root, and they can mimic the symptoms of a disc protrusion from one level more cephalad of the level that we are examining. For example, if patients have a multi-level disc symptoms, and the symptoms of patient refers to L3-4 disc, the disc protrusion is usually a posterior bulge that impresses on the L4 nerve root, but a lateral disc at L4-5 will impress the disc protrusion should impress the L5 nerve root, but a lateral disc at L4-5 will impress the L4 nerve root because it has already exited and will cause the same symptoms. If not noticed, the surgeon could performing the surgery on the L3-4 disc, which is the wrong level. The levels are the L4. So notifying the surgeon when there is a disc lateral to the neuroforamen, it's also important because the surgical approach through the lamina will not allow removal of the lateral disc. So if there is a lateral disc, the surgical management will be different, and the level at which the surgery is operated will be also different. Lateral discs are best identified on the axial images. The sagittal images will often show a lateral disc occluding a neuroforamen, but many times the lateral disc will not be extend to the foramen, and the sagittal images might appear normal. So in the axial images, always look for a lateral disc protrusion because it's so important. And in order to better understand what happens during lateral disc protrusion, we can see this diagram here. This is the L4-5 intervertebral disc, and this is the L3-4 intervertebral disc. Here we have the nerve root of the L4, and here is the L5 nerve root. Okay, so what happens if in the usual disc protrusion, the central or paracentral disc protrusion, is that this disc will compress the L5 root. However, if a lateral disc is present, the compression will be on the L4 nerve root, which has already exited. So instead of if this nerve root was the symptomatic one, okay, and the surgery will be performed, and we didn't recognize this one, we just recognize this one. The surgery will be performed here on the L5 nerve root, which is the wrong level. We should perform it here on the L4 nerve root, which is the correct level. So instead, if you imagine what will happen, again, I will repeat it so that we can understand it better. If there is a lateral disc protrusion here, it will compress the L4 nerve root, okay, resulting in symptoms that might mimic the L3-4 disc protrusion. So the surgery will be performed on the L3-4 instead of being performed on this, the L4-5, which is the disc that's causing the symptoms. Okay, so that's why we need to confirm if there is a lateral disc protrusion. Regarding spinal stenosis, it has been classically classified into into two types, congenital and acquired types. But even with the most severe forms of congenital stenosis, there will be not causing symptoms unless there is a component of acquired stenosis. So it will be a super added conditions that will make congenital stenosis apparent or clinically symptomatic. A more useful classification of stenosis is on anatomic basis, whether it's a central canal stenosis, neuroforaminal stenosis, or lateral recess stenosis. One must realize that the stenosis and the disc disease are often present. Regarding central canal stenosis, there are a lot of studies that shows the different kinds of measurements of the central canal, the AP diameter, the cross-sectional area, and things like that. However, most of them are not considered any more valid indicator of the disease. Instead, just noting whether the thecal sac is compressed or round, it will reliably determine the central canal stenosis just by using your eye and determining whether there is a spinal canal stenosis or not. A subjective assessment as to whether a compression is mild, moderate, or severe is all that is necessary for evaluating the central canal stenosis. So, the most common cause of central canal stenosis is degenerative disease of the facet joints with bony hypertrophy that encroaches on the central canal. The facet joints will undergo degeneration, will form osteophytes, will be hypertrophied, they will narrow the spinal canal, and also they are most common cause of lateral recess stenosis. When the facet undergoes degenerative joint disease, they often have some slippage. They slip over each other, and this will cause buckling of the ligamentum flavum that we commonly refer to as ligamentum flavum hypertrophy, and this in turn will also result in central canal stenosis. Frequently, mild disc bulge is associated with minimal facet joint hypertrophy and ligamentum flavum hypertrophy. So all of these factors together will result in severe focal central canal stenosis. Both CT and MRI will show these bony and soft tissue changes and will enable us to determine the cause of the spinal canal stenosis. But less common causes, they include bony overgrowth from Paget disease, achondroplasia, post-traumatic changes, and severe spondylolisthesis. For example, you can see here there is obviously bilateral facet joint hypertrophy, facet joint disease, with buckling or hypertrophy of the ligamentum flavum, while the disc protrusion is not that significant, but the combination of the three abnormalities resulted in severe central canal stenosis. Again, here you can see ligamentum flavum hypertrophy causing spinal canal stenosis. Regarding spondylolysis, CT here will be more helpful than MRI in determining the spondylolysis. Although MRI will show spondylolysis defects, but these defects can be sometimes very difficult to see. Spondylolysis is identified on the axial images through the mid-vertebral body. What will happen, there will be a break in the normally intact bony ring of the lamina. The lamina is broken, and this will result in spondylolysis. This can result in spinal canal stenosis. This is another case of facet joint hypertrophy on the left side, and this hypertrophy is so severe this is causing spinal canal stenosis. Regarding the spondylolysis, there is a grading system that is so common, it's used almost everywhere, determining the severity of the spondylolysis, dividing the vertebra into four fragments, and if the spondylolysis is under 25%, it's called grade 1. If it's under 50%, grade 2, and grade 3, and grade 4, and so on and so forth. So, regarding postoperative changes, failed back surgery is unfortunately common. It has many causes, including surgical techniques like missed free disc fragments, postoperative scarring, failure of bone grafting for fusion, and recurrent disc protrusion. All of these are causes of failed back surgery. So CT is useful in the evaluation of bone grafts, whether they are fused or not, but it is not reliable for differentiating scar from disc material. MRI is very helpful in this case. For example, we can see here, this is a case of failed back surgery with recurrent spinal canal stenosis. You can see here if the soft laminectomy, there is no lamina here, but there is some soft tissue signal abnormality, and when you give contrast, this soft tissue abnormality will enhance, indicating that this is just a postoperative change causing fibrosis. This fibrosis is encasing and compressing the spinal canal, leading to failed back surgery. Regarding the bony abnormalities of the spine, the thing that we should know about these changes will result in appearance of parallel bands of maybe high, maybe low signal intensities adjacent to the vertebral end plates, and they are commonly seen with MRI in associated with degenerative disc disease. The most common type is type 2. We'll talk about it later, but what will happen is that these parallel bands will be hyperintense on both T1 and T2 weighted images. There is a classification system called MODIC classification system, in which it will classify these changes, the MODIC changes, into type 1, type 2, and type 3. Basically, what happens is that type 1 are edema, type 2 are fat, and type 3 is sclerosis. So, in type 1, because it's edema, it will be hypointense on T1 and hyperintense on T2. While in type 2, because it's fat, will be hyperintense on T1 and T2 weighted images. And in type 3, because it's sclerosis or calcification or whatever you call it, it will be low on T1 and on T2. Of course, the most common of all of these changes are type 2. Type 2 are very common, and radiologists see them on daily basis in multiple patients. For example, this is a case of MODIC type. It's hyperintense on T2 and it's slightly hypointense on T1, indicating fluid signal intensity, or edema, indicating it's MODIC type 1. Okay. However, if you look here, the disc has a low signal intensity, indicating that this is not a spondylodiscitis. There is no inflammation of the disc. So these are just MODIC changes. This is a very important thing to notice, because we have to differentiate MODIC type 1 from spondylodiscitis. For example, in this case, there is also the changes at the vertebral end plates that appears hypointense on T1 and hyperintense on T2 weighted images, indicating MODIC type 1 changes. But if you look carefully, the disc here is hypointense on T1 and hyperintense on T2. This indicates that the disc is also edematous. So this is not a case of MODIC change. This is a case of spondylodiscitis at L4-5 level. This is a very important thing to notice and to differentiate, because MODIC changes are just degenerative changes of relatively low clinical significance, while spondylodiscitis is a big issue that need further evaluation and investigation and treatment. So we should be careful to differentiate MODIC type 1 from spondylodiscitis. That will be all for the neuroradiology chapter of the book of the fundamentals of neuroradiology. Next week we'll see you, and we will start with the chapter on the chest radiology or the respiratory radiology. Thank you very much.